Good morning, good afternoon, good evening, whatever the time is, and from wherever you are watching. Welcome to our symposium on current research at the Institute for Family and Sexuality Studies. I will start by saying a few things about the Institute and then I'll introduce today's speakers to you. The Institute of Family and Sexuality Studies is part of KU Leuven, also known as the University of Leuven in Belgium, and it was founded in 1961. It is one of the first and still one of the few centers in Europe devoted to the study of sexuality, family and relationships. We have a master's program in human sexuality. We offer clinical services and training, and also we have a research program, and we will share some of our ongoing work with you today. In our research program, we apply, generally speaking, a biopsychosocial perspective, and we use qualitative and quantitative research methods, and often combinations of the two. So studies may include interviews, focus groups, questionnaires, experience sampling methods. We also conduct psychophysiological studies, we may measure hormones, and we do fMRI research. And today's symposium will present you with some findings of research on sexual desire, sexual arousal, sexual communication and renegotiation, and sexual and relationship satisfaction. Some of the samples are clinical, some are non-clinical. And the speakers for today include me, Sofia Prekatsunaki, Rick Roels, Alexandra or Ola Pavlovska, Frauke Klaas and Paul Enslin. And in addition to the methods I just mentioned, today's talks will also, some of them at least, include narrative literature reviews and clinical case studies and even couple observations. An important goal in general of our research is to contribute both empirically and conceptually to our understanding of sexual relationships from a dyadic perspective, with not the individual or individuals, but the couple as focus of study. As the first presenter, I will talk with you a little bit about sort of changes and current trends in research on sexuality and relationships. And the title, The Realm of You, is actually inspired by a poem from Emily Dickinson. Sex research, historically speaking, tends to focus on the individual. That is, the individual tends to be the unit of measurement as well as the unit of analysis. And that means that research methods rely on the collection of information and data through or from an individual. That includes interview methods, questionnaires, diary studies, all sort of the methods that I discussed earlier at the start of this symposium. In most cases, even when we ask about others, we ask an individual about others. We don't often include the other in our research, at least historically. There are exceptions. For example, Masters and Johnson, who did very important research on human sexual response, observed not just sexual arousal and sexual responses in individuals, but also in couples, in diets, in people having sex and engaging in sexual activities together. So they made a lot of observations. They collected a lot of data in diets. However, their model, which we all came to know as the human sexual response model, still focuses on the individual. The data they collected, they did not use to develop a model about how sexual response may come about in interaction with another, how the responses of the other may affect you, and how your responses may affect the other. And this applies to many other sexuality-related models, especially models, theoretical models on sexual desire, motivation, sexual response, sexual functioning. For example, incentive motivation theory, an influential way of looking at sexual motivation, focuses largely on the individual. Models of sexual aggression, including Malamuth's confluence model of sexual aggression, doesn't incorporate any elements that are relevant to interactions with others, even when applied, for example, to sexual aggression in a relationship context. Dyspareunia, pain during sexual activities with a partner, models about this do not really incorporate directly, at least most models, the role of the partner and the influence of partner and dyadic processes on the experience of and anticipation of pain. Sexual desire, Basson's model on sexual desire, does emphasize the importance of intimacy and connections with the partner, but the model ultimately is about sexual desire as experienced by an individual and not how that may impact desire of the other or the other's desire impact on yours. Today we will hear more on sexual desire from a dyadic perspective. In particular, Sofia Prekatsenaki will talk about this in a few minutes. And the dual control model, which I am a co-developer of myself, I co-created this with John Bancroft, is a model on sort of the influence of sexual inhibition and excitation on sexual responses and associated processes, and it strongly focuses on the individual, even though these processes too one can expect to really depend on interactions with others and within the dyadic context. There's nothing wrong with focusing on the individual. Of course not. But we miss out if the experiences and behaviors we try to explain involve others, as they often do when it comes to sexuality. Interpersonal interaction is a fundamental component of human sexuality. Individual functioning is part of a system that includes implicit and explicit rules, roles, and expectations, and our sexual thoughts, feelings, actions, even our physiology. And we will hear more about this today as well. Talk by Ola Pavlovska will focus on questions related to even our physiology. They impact and are impacted by others. And I'm grateful to Holmes, Gallivan, and Prooks for summing it up so nicely, this view and this perspective. And there are lots of examples, of course, that are in many cases dyadic in nature: sexual desire, arousal, sexual dysfunction. There's a lot of research on risky sexual behaviors, unwanted, non-consensual sex, but there's not a whole lot yet when it comes to those kind of topics that really explores this from a dyadic perspective. Sex in the context of relationships, but also dating, casual sex, etc. Historically, there are some interesting exceptions and examples. Leonore Tiefer and Arnold Melman many years ago wrote about the importance of including the partner in the evaluation of even something as seemingly individual based as erectile dysfunction. And these are other pioneers who have focused or paid some attention to this. Ray Rosen and colleagues, this is actually studied I was involved in years ago, in which the partners were interviewed, of course, in the context of the use of Viagra. Of course, they were not necessarily interviewed together, but it is an example of how in the past some studies, of course, have acknowledged the relevance of including partners and looking at things from a more dyadic perspective. The role of the partner in erectile dysfunction. So even in that area, you can find examples. And when it comes to a topic like sexual communication, something that Rick Rules will talk about later more as well, there are examples of even questionnaires that ask about communication, and even, they may even be called dyadic sexual communication questionnaires. But it's still asking the individual about basically dyadic processes. All right, well, it's one thing to collect data in couples and or in diets, and of course a lot of methodological issues are involved in doing that. But one of the reasons I think why it has taken some time until the change that we're witnessing now, where there's more attention for dyadic processes and involvement or inclusion of the partner, is that we didn't necessarily have the best tools statistically also to analyze data in couples. And that has changed and is still changing. A great example that has had a major impact in this area is the actor-partner independence model, a statistical way of dealing with the fact that the data of couples, of two partners are who live together, who share a life together, are correlated, and that is a challenge statistically, and that is basically being and has been resolved through approaches like this, which have made a major contribution to it. And that sort of statistical modeling allows us to look at the effects of the actor, of one person on the partner, and of the partner on you, so in both directions. Again, we will hear some examples of how you can apply this in research on couples and sexuality today. There are other methods, statistical methods that I won't discuss today, but they are examples of a trend, of a new development that will allow and that hands researchers the tools to examine dyadic processes, also statistically in more advanced and sophisticated ways. I will quickly give a few examples, but we will hear more today. For example, when it comes to our own model of sexual excitation and inhibition, a study by Julia Velton and colleagues showed that men's sexual excitation scores were positively associated with their own sexual function, but only if they had a partner who also scored high on sexual excitation. So this is really including the data of the partner. Another example, studied by Marieke de Witte and others, men's levels of intimacy were more strongly influenced by how their female partner was feeling and behaving than vice versa. Example of how you can use the data of both partners and come to new insights and conclusions that really are dependent on the interaction between two people. Another example, Alexander Stuhlhofer and colleagues, men's but not women's reports of intimacy were predictive of the other partner's sexual well-being, again including data from both partners. So I mentioned some models at the beginning, and I think one of the things that we will see happening more in the future is not only that dyadic approaches will be applied to data collection analysis, but hopefully will also inspire and stimulate the development of models of sexuality, sexual functioning, sexual response, desire, that are dyadic in nature. And there are some examples of models in which researchers try to incorporate partner processes and dyadic processes, I should say. Rosen and Bergeron have developed a couple emotional regulation model in which they look at regulation from a dyadic perspective. Really interesting work. Also, another example about which you will hear more today. Sofia Prekatsanaki and colleagues, Luc Gijs and Paul Enslin, developed a model of sexual desire that is dyadic in nature, and you can see it's part of the name, dyadics. You will hear more about that today. So, to end, most research, sexuality-related research, has traditionally, historically, really focused on the individual, and even when the questions involve relationships, the data collection is often based on or limited to individuals. There are changes, we see changes in this, and hopefully this will also lead to new development of not just more general approaches in measurement and analysis, but also in theoretical models and thinking about how sex works in a dyadic context. And obviously, we can go beyond that in terms of networks and community cultural processes. This is a nice slide to illustrate that. I'm going to leave it at this, and I hope you will enjoy the talks that will follow and that will share with you different ways of looking at relationship processes in the context of sexuality. And thank you. Our next speaker is Sofia Prekatsunaki, a PhD student and assistant in education and research at the Institute, and she will talk about dyadic sexual desire in romantic relationships.
So, hello, I am Sofia Prekatsunaki, and I'd love to talk to you today about dyadic sexual desire in romantic relationships. So, the reason for this focus is two-sided. On the one hand, sexual desire has strong links with personal and relational well-being. For example, empirical research has often shown that sexual desire is positively related to sexual and relational satisfaction. On the other hand, sexual desire often seems to decrease the longer a relationship lasts. A decreased sexual desire or a discrepancy in sexual desire between two partners is actually one of the most common reasons for sex therapy. Thus, it is important to elucidate on how sexual desire works within a relationship. But what is sexual desire? Well, sexual desire is defined as the interest, wish, or subjective experience of a tendency to engage in sexual behavior. When it comes to the desire to be sexual with ourselves, we speak of solitary sexual desire. When it comes to the desire to be sexual with another person, we speak of dyadic sexual desire. In this presentation, I will focus on dyadic sexual desire that focuses even more specifically on one's own partner in a romantic relationship. When it comes to determinants of such desire, much attention until now has been paid to psychological and biological processes that take place at the level of the individual. Within the clinical practice, however, it is increasingly recognized that sexual desire is not only an individual matter, but closely linked to the interaction between two partners. Empirical studies provide more and more evidence for the importance of dyadic processes for sexual desire, but these clinical and empirical insights are not well integrated yet with each other and in theoretical models of sexual desire. To fill this gap, I would like to propose a new model, dyadics, which stands for dyadic interactions affecting dyadic sexual desire. Dyadics is inspired by a systems theoretical approach to sexuality and focuses on how the input of both partners creates their unique interactional context and influences their sexual desire for each other. I will firstly introduce the model briefly and then share some preliminary results on its empirical testing. In short, dyadics argues that partners shape their interactions through taking, giving, and receiving. In other words, through asserting one's own needs in interactions with the partner, being responsive to the needs of the partner, but also through the perception of the partner's responsiveness to one's own needs. PPR in short. Partners do the first two from their role as a subject, as an actor, an active contributor to interactions. And the last one from a role as an object, as a receiver and observer. So from these two roles, partners interact with each other, and they do so in three different but interconnected domains, namely the domain of sexuality, the domain of affiliation, and the domain of exploration. The first domain of interactions between partners in a sexual is the sexual domain. And this is how the interaction elements that we have just identified take form in this domain. Asserting one's own needs takes the form of sexual subjectivity, which refers to experiencing oneself as a sexual being, a being that is entitled to sexual pleasure, makes sexual choices, and consciously reflects on one's own sexuality. Being responsive to the needs of one's partner takes the form of sexual communal strength, which refers to the willingness to meet the sexual needs and desires of the partner. And when it comes to how one perceives the responsiveness of their partner, in other words, what one receives from the partner in their interactions in this domain, that is related to responsiveness to one's sexual needs, of course, but also to validation for one's value as a sexual being or the feeling of being desired by one's partner. Qualitative and quantitative research has shown that asserting one's own sexual needs, as well as the willingness to meet the needs of one's partner and feeling desired by this partner, are important determinants of sexual desire in a romantic relationship. In the second domain, the domain of affiliation, the focus on one's own needs is related to the positive affect one feels for the partner and the need for emotional closeness with this partner. In other words, to feelings of love for one's partner and to wanting to be close to them. Being responsive to the needs of one's partner in the domain of affiliation takes the form of wanting to express this affection and love towards this partner, but also to protect one's partner, to take care of them, also known as communal strength. And perceived partner responsiveness in this domain refers to receiving affection, love, comfort, help, protection by one's partner, or feeling loved, understood, and supported. Research on intimacy and attachment has shown that also these interaction elements are associated with sexual desire in both early and long-term relationships. The last domain of interactions relevant to dyadic sexual desire, according to dyadics, is a domain of exploration. Interactions in this domain have not received much attention yet when it comes to their role for sexual desire, but they are all linked to a basic human need for exploration, for cognitive curiosity, a motivation for self-expansion and personal growth. Empirical support is still scarce, but there is already evidence that exploring and pursuing one's own goals, but also pursuing couple growth and supporting the growth of our partner, as well as receiving support from our partner in our self-expansion process, all have a positive effect on sexual desire in romantic relationships. So these are the partner interactions and their elements that, according to the dyadics model, are important for sexual desire between partners in a romantic relationship. Partners interact with each other as subjects and objects in the interconnected domains of sexuality, affiliation, and exploration. And the combination of these interactions determines their sexual desire for each other. But besides the theoretical consideration of these processes, it is of course useful to empirically test this model and instill insights for the clinical practice. To this end, I will now discuss some preliminary evidence, some findings from one study on dyadic sexual desire in women, and specifically women in the postpartum period. There is nowadays increasingly recognition for the physiological and psychological changes that characterizes this period, and the fact that the transition to parenthood is a great challenge for the couple relationship and for couple sexuality. Unfortunately, there is still little research on what this transition to parenthood actually means for partner interactions and how changes in these interactions could help understand how sexual desire works when partners become parents. That is why we asked 119 women about this, 3 to 12 months after they gave birth to a child. We first collected information on obstetric factors that have previously been shown to affect sexual desire or other aspects of sexual functioning in the postpartum period, but none of these were actually found to be related to sexual desire in our sample. We also collected information about these women's interactions with their partners. These data showed that especially sexual subjectivity and sexual communal strength, but also communal strength, are positively correlated with dyadic sexual desire. It is worth noting that the perceived partner responsiveness was not found to be related to dyadic sexual desire. However, PPR did correlate strongly with interaction elements that are linked to sexual desire, such as sexual subjectivity, sexual communal strength, and communal strength, and as such may exercise an indirect influence on dyadic sexual desire. To gain a better understanding of how these interactions relate to other periods in the relationship between partners, we compared the data of these postpartum women with data of 209 control women of very similar mean age and relationship duration, of whom 152 had no children and 57 had one or more children older than 1 year. Based on analysis of variance, we found no significant difference in sexual desire between the different groups of women. However, we did find significant differences in elements of partner interactions. These differences were mostly found between women in the postpartum period and women without children. They included lower sexual subjectivity for women in the postpartum period, lower sexual communal strength, lower need for emotional closeness and positive affect for the partner, lower self-expansion, but also lower responsiveness of the partner in the domains of affiliation and exploration. These results are in line with theory and previous findings about changes in the partner relationship during the transition to parenthood, but provide a little bit more insight into the content of these changes. Despite the differences in partner interactions that we have just talked about between the three groups of women, sexual desire appears to be largely related to the same interaction elements. Sexual subjectivity, sexual communal strength, and communal strength are related with dyadic sexual desire across the three groups, which suggests that the way in which partners interact with each other remains important for women's sexual desire for the partner also after the transition to parenthood. Although these are preliminary results, they do offer valuable insights for the clinical practice, which I'd like to summarize in 3 take-home messages. First, the data on sexual desire support a dyadic approach to sexuality and sexual problems. By recognizing the role of each partner as a subject, the dyadics model provides tools for the exploration of personal agency, but also responsibility for co-creating sexual desire within the relationship. The recognition of the role of each partner as an object in the different domains of partner interaction recognizes the importance of partner validation and the interdependence between relationship partners. Second, the fact that aspects of sexual interactions show the strongest correlation with sexual desire seems to indicate that sexual desire is mostly about sex. While this is not surprising, it is not entirely in line with therapeutic approaches such as emotionally focused therapy, which assumes that if intimacy and the relationship are repaired, the sexual relationship will naturally follow. A therapeutic focus on the emotional connection remains important, of course, as it can help ensure relational prerequisites for relational sexual desire. However, our preliminary results suggest that an explicit focus in therapy on the sexual interactions between partners may be needed because they are the ones that are most strongly associated with sexual desire and thus potentially make the biggest difference. But the last and most important take-home message is related to the finding that dyadic sexual desire is associated with many different dynamic aspects of partner interactions. We believe this finding supports a constructive and hopeful view on sexuality. Rather than a mysterious instinct beyond our control, determined solely by biological factors or stable personality traits, dyadic sexual desire seems to be linked to tangible interactions between partners, interactions that actually lie in the sphere of influence of therapists, but especially in the sphere of influence of partners themselves. And that creates a world of opportunities for sexual desire in romantic relationships and for finding and sustaining sexual and relational happiness. Thank you very much for your attention.
Thank you, Sophia. Our next speaker is Rick Roels, psychiatrist, sexologist, and PhD researcher, and he will talk about affective and behavioral dimensions of sexuality and their relevance to relationship satisfaction. He will talk about a dissertation project, as Sophia did, and which involves a multi-method study in young heterosexual couples.
Hello everyone, my name is Rick Roels. I'm a PhD student at the Institute for Family and Sexuality Studies in Belgium, and my PhD advisor is Professor Eric Janssen. Today I will present the main findings from my research project, which distinguishes between affective dimensions of sexuality and behavioral dimensions of couples' sexual relationships. Sexuality is an important part of most intimate relationships and can be associated with both positive and negative outcomes, and is strongly associated with individual and relational well-being. To support this well-being, it is necessary to understand how and for whom sexual aspects of the relationship influence the couple's relationship. The current research project aims to fill critical gaps in our understanding of the associations among sexual and non-sexual relationship processes and couples' relationship satisfaction. By applying a dyadic perspective in the study of sexuality, we hope to address limitations of prior sex research, which often focuses on individuals, as well as prior relationship research, which often excludes the sexual dimension from their study scope. This way, we aim to promote the knowledge of the characteristics of fulfilling romantic and sexual relationships by considering the perspective of both partners in the relationship. In doing so, we hope to pave the path to fruitful directions of future research at the intersection between sexuality and relationships. Why do we focus on the early stages of romantic relationships? Studies, including longitudinal ones, have found that most changes in couple dynamics, especially those involving changes in the sexual frequency, are expected to occur during the first years of a relationship. Specifically, research on long-term relationships has consistently found that the frequency of sexual interactions is highest during the first few years of the relationship, after which it tends to show a sharp decline. Despite empirical support highlighting the role of sexuality in the first years of romantic attachment, there remains a great paucity of scientific studies zooming in on those early stages of romantic relationships. We collected data from 126 young heterosexual couples between 18 and 30 years of age, who were in the early stages of their relationship. The analysis was done via multi-level modeling and the actor-partner interdependence model. Here's a brief overview of the key demographics of our sample, which shows that we specifically included young couples in the first years of their relationships with an average relationship duration of 1 year and 10 months. Now let's focus on our aims and how our findings contribute to the current state of the art. Our first aim was to examine the importance of sexual frequency and sexual communication in our sample. To date, the question remains, how important are sexual communication and sexual frequency for relationship satisfaction in the early stages of romantic relationships? Our APIM analysis revealed two things. First, in our sample of young heterosexual couples, sexual satisfaction was significantly associated with sexual communication and sexual frequency. When it comes to relationship satisfaction, however, only significant associations were found with sexual communication, and we found no significant associations with sexual frequency. Next, we wanted to look at the importance of sexual behaviors early in romantic relationships by zooming in on the behavioral characteristics of the sexual relationship and their relevance to relationship quality. Specifically, we aim to examine the associations between different sexual behaviors and relationship satisfaction and test the impact of both partners' attachment dimensions on these associations. Considering our prior finding that sexual frequency in se doesn't matter as much as sexual communication for relationship satisfaction, for whom does sexual frequency matter? Specifically, our aim was to investigate the complex interaction between attachment, relationships, and sexuality. The development, maintenance, or rupture of attachment relationships is said to underlie the strongest emotional experiences that people can experience during their lifetime. Thus, better understanding these attachment processes and the underlying or associated mechanism is an important part of past as well as future psychological research, where there is still much to discover about the role sexuality may play in them. In our sample, we found that one's own and one's partner anxious attachment was negatively associated with relationship satisfaction, and similar results were found for attachment avoidance. We found no gender effects. Next, we examined moderation effects. It should be noted that averaged across women and men, there was no significant main effect of sexual frequency on relationship satisfaction. However, we did find a significant positive correlation between sexual frequency and relationship satisfaction in individuals scoring higher on attachment anxiety. We found no significant partner effects of attachment anxiety and found no significant moderation effects of attachment avoidance. As we found in our first study that sexual communication was more important than sexual frequency in the evaluation of one's relationship, for our next aim, we investigated the topic of couple communication. Specifically, our third aim was to examine the characteristics of observed couple communication behaviors during sexual and non-sexual discussions and their associations with relationship satisfaction. Couple communication can be assessed using self-report questionnaires, and though this method can offer interesting insights in how partners experience communication, they do rely on the participants' perceptions of their own or their partner's communication style and skills. Another way to assess communication between romantic partners involves videotaping couples as they discuss problem areas in their relationship and then coding these recorded interactions for theoretically relevant themes, such as positive and negative affective expressions. However, up to now, little attention has been made to conflict topic in observational studies. Our research questions for aim 3 were twofold. First, are there differences in the ways couples navigate sexual and non-sexual couples discussions? And second, how are these communication behaviors associated with relationship satisfaction? In the present study, we asked our participants to engage in sexual and non-sexual conflict discussions. The 2 7-minute discussions were videotaped and rated by trained coders on 9 behavioral dimensions using an adaptation of the specific effect coding system and the system for coding interactions and family functioning. Coder ratings applied to the discussion as a whole, and analysis included factor analyses as well as multi-level modeling incorporating the actor-partner interdependence model. The factor analysis revealed three factors. The first factor represents negative behaviors, included level of conflict, contemptuous behaviors, domineering and belligerence, and annoyance and frustration. The second factor represents affectionate behaviors, included likeness, collaboration, and affection. The third factor represents validating behaviors and included understanding and validation and interest in and seeking out partner perspective. On average, more negative behaviors were displayed during non-sexual discussions than during sexual discussions. In addition, compared to non-sexual discussions, sexual discussions were characterized by higher levels of both affectionate and validating behaviors. In addition, a significant main effect for gender was found for negative behaviors, with women on average displaying more negative behaviors than men during the 2 discussions. No other significant main or interaction effects were found. Our results further show that for the negative behaviors during non-sexual discussions, they were associated with relationship satisfactions in oneself and in one's partner. For the sexual discussions, men who engaged in greater negative behaviors were more likely to report lower relationship satisfaction, but this association between negative behaviors and relationship satisfaction was not significant for women. The opposite was found for partner effects, which were only significant in women, indicating that women whose partner expressed more negative behaviors during the sexual discussion were less satisfied in their relationship. For the affectionate behaviors, no significant actor effects were found. However, we did find significant partner effects indicating that greater displays of affection by one's partner were associated with higher relationship satisfaction of the actor. For the sexual discussions, the analysis revealed significant actor effects and partner effects, indicating that participants who displayed greater affection during the sexual discussions were more satisfied themselves and also had more satisfied partners. For the validating behaviors, we did not find significant actor effects for validating behaviors during non-sexual discussions. However, we did find significant partner effects during this discussion, indicating the partners of participants who displayed higher levels of validating behavior during non-sexual discussions were more relationally satisfied. For the sexual discussions, no significant actor effects were found, and there were significant partner effects. Next, we will address our fourth and final aim. Our fourth aim was to explore the neurophysiological underpinnings of sexual communication by studying the association between oxytocin and observed communication behaviors during both couple discussions. Relationship conflict and distress negatively impact physiological functioning and health and are risk factors for depression. Although the literature on the association between relationship satisfaction and physical and mental health continues to grow, the physiological and neuroendocrine mechanisms underlying such associations are still not fully understood. The role of oxytocin in promoting prosocial and affiliative behaviors has received increasing attention. The current study aims to increase our understanding of oxytocin in romantic relationships and is the first to assess the relationship between peripheral oxytocin levels and perceived communication behaviors during sexual and non-sexual conflict conversations in romantic relationships. To date, oxytocin appears to be associated with different and possibly contrasting findings depending on situational and individual factors. Thus, our fourth research question was, how are peripheral oxytocin levels associated with communication behaviors during sexual and non-sexual discussions? We found that for both women and men, oxytocin levels were significantly correlated with validating behaviors during sexual discussions, and we found no significant correlations between plasma oxytocin levels and validating behaviors during non-sexual discussions, nor were significant correlations found between oxytocin and negative behaviors and oxytocin and affective behaviors during sexual or non-sexual discussions. To fully examine the dyadic nature of our data, we examined the significant associations between oxytocin and validating behaviors during sexual discussions using the APIM model. Results showed significant main effects for both women and men, indicating that women and men who exhibited more validating behaviors during sexual discussions had higher plasma oxytocin levels. In addition, we also found significant partner effects, meaning that higher levels of validating behaviors were associated with higher levels of oxytocin in one's partner. This is in line with prior findings that express the value of including the dyad as a unit of analysis for a more complete biobehavioral matrix that focuses on all possible interactions between hormones and behaviors. While hormones may influence relational behavior, the reverse should also be considered, where relational behavior may influence hormone levels. So what are our overall conclusions? First, sexual communication outweighs sexual frequency in the evaluation of one's relationship. Second, individual characteristics such as attachment anxiety determine the importance of sexual frequency to the evaluation of one's relationship. Third, there are unique qualities to observed sexual communication, with couples overall showing less negative and more positive behaviors compared to non-sexual communication. Fourth, expressions of positivity were associated with greater relationship satisfaction. And fifth, gender differences in the associations between expressions of negativity during sexual communication and relationship satisfaction are found. Sixth, neurophysiological involvement in the sexual communication patterns of couples point at the need for further research on the neurohormonal basis of sexual communication. Although we recruited a community sample and not a clinical sample for this study, our findings hint at a potential positive impact of focusing on sexual communication. Whether integrating sexual communication in couple therapy may improve both sexual and relationship satisfaction should be explored in further studies, including therapy-seeking couples. Thank you very much for your attention.
Thank you, Rick. Our next speaker is Alexandra, or Ola Pavlovska, a PhD student, a joint PhD student with our program at the University of Leuven and Maastricht University, and she also works there with Dr. Marieke de Witte. And Ola will speak about her research on sexual arousal as a dyadic process. And she will present the study designs and conceptual considerations that are part of this endeavor.
Hello, my name is Ola, and I'm currently doing my PhD at Maastricht University and at KU Leuven under the mentorship of Dr. Marika de Vita and Professor Erik Jansen. Today, I'm going to talk about the importance of dyadic processes in sexual arousal in the context of my PhD project. Although measurement of sexual arousal in the laboratory has provided us with important insights into the processes that facilitate and inhibit sexual responses, thus far, this body of work has largely relied on an assumption that sexual arousal experienced alone in the research laboratory develops in the same way as with an intimate partner at home. Yet, evidence shows that partner presence in the lab can influence sexual arousal development. Consequently, it is clear that our understanding of sexual arousal as a dyadic process remains limited. Development of dyadic models and empirical research designs in the field of sexuality can improve both the ecological and external validity of studies, but also inform clinical practice by showing how relationship variables can serve as risk or protective factors in development and maintenance of sexual problems. The sexual system can be seen as an emotion regulation device involving a dynamic interaction between attention, behavior, affect, and physiological components. Individual partner relationship and contextual characteristics shape the way in which sexual emotions are experienced. As an example, the stress experienced during sex with a partner can have a direct effect on sexual responses of both partners, for instance, by lowering their arousal levels, thus influencing their sexual experience. However, positive partner responses, such as provision of support, can alleviate the experienced distress, while negative partner responses, such as avoidance, can exacerbate it, having a further effect on future sexual interactions between the partners. In this way, partners' emotions and emotional responses guide and coordinate subsequent sexual interactions, effectively shaping their sexual dynamics and the way in which they regulate their affect during sex. Over time, partners' sexual responses may become dependent on each other or simply interdependent. To better understand the nature and function of partner interdependence and relational processes in sexuality, in my doctoral project I focus on one specific type of partner interdependence, synchrony, and I apply its principle to sexuality research. Synchrony is commonly conceptualized as a mutual influence and predictive matching in time and form of affective, behavioral, and physiological responses between two individuals. This means that partners adjust their responses simultaneously by predicting each other's responses over time. In established relationships, through repeated interactions, partners become more sensitized to each other's cues and rhythms and get better at accurately matching their partner's states, leading to interdependence between partner responses. In intimate contexts, sexual synchrony could be observed through matching in form and intensity of vocalizations, facial expressions, or movement patterns, genital arousal, heart rate, respiration, or subjective sexual arousal between the partners over time. As partners continue to be close and intimate with one another, their sexual rhythms may become interdependent, creating a dyadic sexual system that serves a regulatory function and determines sexual outcomes for both partners. Thus, synchrony offers a dynamic interpersonal framework for studying dyadic processes in sexual responding. Generally, synchrony is thought to promote the ability of an individual to self-regulate and regain physiological balance through the significant other. Synchrony patterns aimed at increasing positive emotions, where negative emotions are acknowledged but not exacerbated, create a safe and secure relational climate, contributing to the longevity and quality of intimate relationships. Experiencing these patterns of synchrony allows partners to seek out support following negative experiences, which further buffers against interpersonal stress. Yet, empirical evidence shows that these synchrony effects differ according to a number of individual, partner, relational, and contextual variables, such as relational climate, attachment orientation, interpersonal goals, susceptibility to partner influence, and empathic accuracy. Synchronizing one's responses with those of a relationship partners during intimacy can have a direct influence on sexual arousal of both partners. In that sense, partner and relationship characteristics can serve as risk or protective factors for development and maintenance of sexual problems. For instance, experiencing pain in intimate situation can interfere with sexual arousal of the affected individual, activating feelings of fear and anxiety. If the partner of the affected individual synchronizes with that individual, then the process of synchrony may interfere with sexual response of both partners, which can bear negative consequences for their sexual and relational outcomes. However, if the partner remains positive, supportive, and encouraging, then synchronizing with the partner could facilitate sexual response and positive relational and sexual outcomes. Thus, sexual experiences and synchrony effects will differ between individuals with different sexual and relational schemas. There are different types of assessment methods that could be used to capture synchrony processes in intimate situations. Some of them can be used in the laboratory, while others allow for ambulatory assessment. Using these methods will enable us to answer some of the yet unanswered questions about the role of individual, partner, relational, and contextual features in determining couple outcomes. I will describe some of these methods and the questions that can be answered using them by presenting examples of study designs from my own research. Our laboratory study was designed to simulate an erotic Skype call between partners. Prior to coming to the lab, partners complete a questionnaire battery assessing their individual and relationship characteristics. During the task, partners sit in separate rooms. First, to simulate a traditional laboratory setup, partners watch a series of 3 short videos, including neutral and sexual stimuli. Then, the partners are connected to one another in a real-time audio-video call. During the call, partners are asked to focus on maximizing their own sexual arousal or on maximizing their arousal as a couple. Throughout the task, we measure heart rate, genital blood flow, as well as subjective sexual arousal. We also record voices of the partners during the call. After the call, partners are asked to listen to their conversation and rate retrospectively their own sexual arousal, as well as estimate sexual arousal of their partner. This research design allows us to test multiple research questions. First and foremost, the study will allow us to establish what effects does sexual synchrony have on relational outcomes, such as sexual or relationship satisfaction, and for whom. Furthermore, we will be able to establish what is the influence of attachment orientation and accuracy in estimating partners' arousal on synchrony effects. We will also be able to examine how do these effects of synchrony differ depending on the goals that partners have in terms of individually oriented or couple-oriented goals for increasing sexual arousal. Lastly, we will be able to determine if partner presence is a prerequisite for sexual synchrony to arise, and to compare the effects of video versus partner as a sexual stimulus on sexual arousal synchrony in couples. To facilitate more ecologically valid designs in sex research, together with a team of engineers, we have developed a mobile data collection system for genital arousal, heart rate, and subjective measurements that allows for ambulatory assessment of couple sexual dynamics. We plan to test the feasibility of this system both in the lab and at home. Similar to the study design mentioned earlier, in each testing session, partners will first watch neutral and erotic video stimuli, after which they will be asked to take turns and manually stimulate each other's genitals, such that first one partner will stimulate the other, then vice versa, and finally partners will stimulate each other's genitals simultaneously. The mobile system will allow partners to move freely, enabling them to enact more realistic behaviors which can reduce the limitations of participant movement associated with the use of stationary systems. It will also allow participants to enact sexual behavior in the most ecologically valid setting possible, their home. If the data recorded at home is comparable to that gathered inside the lab, then this project will open an avenue to ambulatory assessment of dyadic sexual arousal patterns. As relational and contextual variables such as stressors can facilitate the need for synchrony to manage the negative emotions, we tried to make the best out of the pandemic situation, and we designed an experience sampling study to examine the effects of pandemic-related stress on sexual synchrony and relational outcomes. In this study, partners completed 6 short surveys a day for 10 days using their smartphones. The surveys assessed the level of stress associated with the pandemic, relational context, sexual desire, sexual behavior, motives, and outcomes. By looking at these variables, we will be able to disentangle whether, when, and for whom sexual synchrony can buffer against stress over time. In this way, this study can increase our understanding of the reciprocal effects of intimate behaviors and stress. As you have seen, we have designed several studies to measure sexual synchrony between partners in the lab and at home, using various measures. In addition to the direct measurement of sexual synchrony, we are also interested in measuring partners' perceptions of their level of sexual synchrony, because we think it's possible that similarity in those perceptions is as important as the actual sexual synchrony itself. At present, there are no valid and reliable psychometric measures designed to assess interpersonal mechanisms in sex and their implications for relationships. Thus, we are currently developing a questionnaire measure of perceived sexual synchrony. This measure will allow us to evaluate the degree to which sexual partners perceive their behaviors, emotions, and physiological responses to be synchronous, and to provide an index of similarity in partners' perceptions using items such as we both breathe rapidly, our movements are in sync, we know how to turn each other on, one of us is breathing more rapidly than the other. Differentiating between couples who are low and high on perceived sexual synchrony will allow us to examine sexual and relational consequences for these groups of partners. Taken together, these research designs will help us understand the contribution of synchrony processes for relational and sexual well-being across various contexts and using different assessment methods, yielding a comprehensive set of first evidence. This evidence can then help us develop new conceptual models that consider the dyadic and dynamic nature of sexual responding in couples. To sum up, dyadic processes should be at the focal point of research and clinical practice in fields related to sexuality, as partner and relationship characteristics can determine sexual and relational outcomes for individuals, both in daily life as in clinical practice. Novel assessment methods can facilitate this paradigmatic shift from the individually focused to couple-focused theory and practice. Thank you for your attention.
Thank you, Ola. We will move on to the next speaker, and that is Frauke Klaas. She will speak about dementia and sexuality, a story of lifelong renegotiation. And her talk is based on a narrative literature review, and on the basis of that review, she and Paul Enslin developed a new framework to better understand how dementia may affect the sexual relationship between partners. Go ahead, Frauke.
Hi everyone, my name is Frauke Klaas, and today I am very glad to present to you a story on how dementia and sexuality interact. Dementia is a chronic disease which is related to aging, with common symptoms being a loss of cognitive functioning, emotional problems, or behavioral problems. The fact that dementia is a progressive and incurable chronic disease enables us to view it in different consecutive stages, which is the starting point of our newly developed generic framework. In this presentation, I'm going to present to you this framework, which focuses on the sexual relationship of a couple confronted with dementia in a longitudinal manner, phase after phase. It is important that during this presentation you keep in mind that there are, of course, inter-individual differences according to, for example, the type of dementia or the age of onset. As you can see on the picture, the framework looks quite complex at first glance, but we will zoom in on each phase separately. The first phase is the pre-morbid phase, which is the phase before the onset of dementia. It is basically the normal situation of a healthy couple. The only actors involved in the sexual relationship at this point in time are both partners with their own attitudes towards sexuality, making the sexual relationship more or less satisfying for each partner. You might think, why is this an important phase in dementia when there isn't even a diagnosis of dementia yet? Well, the pre-morbid phase has been proven to be very important in the future. So couples who showed a great deal of affection prior to the diagnosis of dementia are known to put in more effort to keep doing so after the diagnosis. This means that affection and sexuality prior to the diagnosis are important predictors of affection and sexuality after the diagnosis. And it is therefore clinically very important to acknowledge the pre-morbid situation of a couple confronted with dementia. After the pre-morbid phase follows the prodromal phase, which starts when the first symptoms of dementia appear, but diagnosis of dementia is not yet made. This phase entails a great deal of uncertainty and stress due to the inexplicable early symptoms, as well as due to misdiagnosis sometimes, such as depression or burnout. During this prodromal phase, the only actors involved in the sexual relationship are still only both partners, but here not only their attitudes towards sexuality, but also their attitudes towards the uncertainty start to play an important role in their sex life. The early symptoms of the prodromal phase, being agitation, apathy, cognitive decline, they can influence sexuality directly as well as indirectly through the uncertainty and stress that they cause. It is basically very likely that both partners are experiencing changes in their intimate and sexual life in this prodromal phase. However, the hardest part here is that they do not yet understand why. Eventually, the dementia diagnosis will be officially made and the couple enters the phase of home care, as long as the patient is living at home, of course. On the one hand, this diagnosis can be very reassuring as it explains the early symptoms, but on the other hand, it is often a painful disruption of life. From this phase on, not only patient and partner are involved in their own sexual life, but healthcare providers and their attitudes towards dementia and sexuality come into play. It is here most important that couples get the feeling that they are allowed to talk about intimacy and sexuality. And healthcare providers therefore need to become comfortable in discussing sexual problems. They need to be aware of their personal biases, and they should initiate a talk about sex, which they can do, for example, by implementing sexual functioning in their routine assessments. In this phase of home care, patients are very likely to experience gradual changes in intimacy and sexuality due to the gradual aggravation of the dementia symptoms. While the majority of patients with dementia, more than 60%, report to remain sexually active, about 2/3 of this group report changes in sexual activity after the diagnosis. Consequently, the sexual dissatisfaction rates are also very high in patients with dementia, as you can see on the slide. However, the sexual experience of patients with dementia varies inter-individually. Whereas most patients with dementia report to remain sexual beings with a contained sexual interest, there are also patients who report a decreased sexual interest or even an increased sexual interest. But of course, not only patients experience these sexual changes in the phase of home care, also their partners have to handle this impact. And even more so than patients, 70% of partners report changes in their sexual activity after the diagnosis. The sexual dissatisfaction rates are consequently also higher in partners than in patients, and they are very high. as you can see. Besides, partners often experience a decline in sexual desire and longing for their specific partner with dementia, and this could be due to several reasons. For example, many partners do not recognize the patient with dementia anymore and find that he or she becomes kind of a stranger to them, making a sexual relationship very difficult. Also, the roles within a relationship start to shift as the patient becomes more dependent and the partner becomes more like a caregiver, which makes the relationship feel less equal and sometimes more like a parent-child rather than a partner relationship. This makes a sexual relationship sometimes feel inappropriate, aversive, or even incestuous. This is very unfortunate because intimacy and sexuality can be a source of pleasure, well-being, and comfort, and it can also serve as a coping mechanism for some partners. Finally, when a patient is in a progressed stage of dementia, admission to a residential care facility might be necessary and the residential care phase is then entered. The family network starts to get involved here in decisions about the couple's sexual life. Family tends to be overprotective towards any sexual behavior posed by the residents, and when sexual behavior does occur in the facility, the family is often contacted and their wishes are mostly privileged over the wishes of the patient. Besides patient, partner, and family, also the healthcare professionals of the facility and their attitudes are inevitably involved. Similar to family, there seems to be an overprotective reflex in staff members to be concerned about any behavior of a resident with dementia, any sexual behavior, The policy of the healthcare organization is therefore very important here, as it determines the staff members' views as well as the possibility of the couple to express themselves sexually. Both family and healthcare organizations seem to struggle with the dilemma between acknowledging the autonomy of the resident versus protecting the resident and other co-residents. Unfortunately, a protective, problem-oriented approach still seems to prevail over a holistic, person-centered approach in many organizations. Research on sexuality in residents with dementia focuses mainly on inappropriate sexual behavior. A sole focus on this type of behavior is problematic as it ignores the subjective sexual experiences of the residents. Residents do show many diverse, intimate, and sexual behaviors, such as holding hands with another resident or masturbation. But the question is then who has the power to define that this type of behavior should be seen as inappropriate or even problematic. This so-called inappropriate sexual behavior could just be an inappropriate expression of a normal need, or it could just be a normal reaction to an abnormal environment. Residents with dementia are somewhat externally controlled in the decisions that they make, and thus also in how they express themselves sexually. And their sexual agency and autonomy are in this way not acknowledged. However, we know that many residents' sexual interests remain, but the opportunities to be sexually active decline due to the overprotection of family and staff and due to no privacy and social control by other residents. However, the residential care phase can be a time for residents to start a new relationship or a new sexual relationship with another resident. For partners of residents with dementia, the admission of their partner to a facility is a disruption of their sexual life as well. Very few couples remain sexually active after one partner is placed in a facility, and this is due to many barriers. For example, there are practical barriers such as a lack of privacy or a single bed, but there are also emotional barriers such as the feeling of guilt and distance due to the admission to the facility. And there are also ethical barriers. As the patient is progressing in the disease, many partners become concerned about the ability of the patient to sexually consent. However, this residential care phase can also for partners mean the start of a new sexual relationship or a new relationship in general. Throughout all these phases, a renegotiation of the partner relationship and the sexual relationship becomes increasingly necessary as the dementia symptoms aggravate and more actors become involved. From the home care phase on, many couples tend to shift from penetrative sex to increased touch and intimacy, such as cuddling and kissing. In the residential care phase, for example, overprotective family and staff members become involved, and there become many barriers to be intimate, which implies that a couple needs to be creative in fulfilling their intimate and sexual needs. Although this renegotiating and reshaping is necessary, it is a process which is far from easy for some couples and needs a lot of time, effort, and support. We can thus conclude that a couple confronted with dementia is likely to experience a big impact on their intimate and sexual lives, and gradually more so when dementia progresses. However, this does not necessarily have to mean a disruption of their relationship or their sexual relationship, as many couples do show resilience and are able to renegotiate their life. A supportive network and an open-minded, holistic, and person-centered approach could help this process, but more research needs to focus on the intimate and sexual impact of dementia in order for couples to gain the support that they need. Thank you very much for listening.
Thank you, Frauke. Last but not least, Paul Enslin will speak about infertility and sexuality, an extreme or prototypical case study. As part of the presentation, he will describe the sexual experiences of a couple that suffers from infertility problems and that signed up for sex therapy after 30 years of sexual inactivity together. We look forward to your presentation.
Hi all. I'm happy to be able to share this presentation that focuses on the sexual sequelae of a couple that suffered from infertility problems and that signed up for sex therapy. The story of this couple is a reason to reflect on the lack of attention and care for the sexual life of couples who sign up for fertility treatment. And the important question to pose is this an extreme or a prototypical case when it comes to discussing sexuality in fertility clinics? I'm Paul Enslin, Program Director of the Institute for Family and Sexuality Studies at KU Leuven, where I teach several courses related to clinical sexology, sex therapy, and sex education. Apart from that, I'm clinically active as a sexologist at the Center for Clinical Sexology and Sex Therapy at the University Psychiatric Center of the same university, a center of which I'm the head. There are probably two perspectives to look at a fertility problem. On the one hand, there is a perspective of the fertility center, which we can call the clinical presentation, in this case of the couple that presented at the fertility center at the end of the 80s. The couple presented at the fertility center when the woman was 29 years old. After 6 months of trying to conceive, they went to the fertility center because her mother also had problems to get pregnant. However, they were sent home first. And over a couple of years of consulting the center, she was diagnosed with endometriosis and went through several unsuccessful IVF cycles. That lack of success was probably also due to the fact that the man, who was 27 years old, received the diagnosis of astenoterato and ogliospermia, meaning that there were no fertilizing sperm cells in his semen. The second perspective is the perspective of the couple. When they consulted me, the woman was 63 years old. She was working as a translator and interpreter at an international company. Her husband was 61 years old, studied nursing and translating, and was also working as a translator in the medical sector. To cope with the unsuccessful IVF treatment, they adopted two daughters, who were 28 and 23 years old, but who did not know about the relational problems of the couple. They were referred to me by a marital therapist because they did not have had sex for 25 years due to the failing treatment for their fertility problems, and they wanted to restart being sexually active together after the man fell in love with another woman, with whom he did not have any sexual relation. When they consulted me, the man also complained about erectile dysfunction. After we ended a successful treatment in which they regained pleasure in having sex together, about half a year later I contacted this interesting couple again for an interview about how they looked at the link between sexuality and infertility treatment. We had an interview for about 90 minutes that I recorded using only audio and that I transcribed verbatim. I analyzed that text using thematic analysis and shared, discussed and checked the themes that emerged with two colleagues. We will now focus more on the link between sexuality and the wish for a child and present a part of the story of this couple. This couple learned to know each other when they were students. They grew in their sexuality, and for about 7 years they told they had a good sex life without any worries. When she was 29 and he was 27, they started to think about having children. This resulted in having more and more satisfying sexual activity that became even more special and exciting because having sex becomes related to the expectation of a higher goal, namely becoming pregnant. The woman expressed this as, therefore sexual activity was surrounded by a kind of positive expecting excitement. And for the man, sex therewith received another meaning. Sex for fun suddenly became sex for real. An important theme that emerged from this interview was that due to the wish to conceive, sexuality became under pressure. When the expected pregnancy does not occur, the pressure on sexuality increases and sexuality becomes a targeted technical act or targeted technical activity. Sexuality became more and more limited to fertile days, and it was done without much of spontaneity, emotions, feelings, and/or pleasure. The woman told, "It is not like that in the first years, but after some times there is no more pleasure. The tension became so increasingly big that, so to speak, it became an assignment, a task for him, and for me it became waiting until it was done. And then the task on the to-do list was done. There was no longer real communication. It was something that needed to happen, but not a kind of exchange of affection or based on sexual desire or so, or something between us." And the man continued, "The fun completely disappears. It becomes a kind of task during which the pressure increases, without any involvement of emotions." Moreover, when the expected pregnancy does not occur, sexuality becomes gradually associated with a feeling of failure, including negative ideas about one's failing body. The woman used the following words: "For, after some time, you're nothing more than a failing couple of ovaries, or a failed uterus, or whatever. That is how you feel. But that was not yet the worst. I just think about the sadness, the disappointment and the pain about it, and the feelings of shame." And the man concluded, "Then of course, sex for fun becomes sex is failure." And when the expected pregnancy does not occur, sexuality becomes even more under pressure, as it is no longer an exclusive and intimate activity between two people, but an activity that, at least in the fantasy of people, is intruded by a fertility specialist who is watching at it in terms of how often, when, and its outcome. The man remembers, after 1.5 years of reassurance, some soft guidelines followed. that was not so pressuring. But afterwards, the despair and lack of hope is growing, or the hope even disappears, based on which the tension progressively increases, and then everything that is related with getting pregnant becomes so important that the fun is completely waning. And then the sadness comes, because you progressively start to realize that it will never happen. And yes, that is very painful, with the pain from the other partner in addition. For this couple, the fact that the expected pregnancy did not occur resulted in the fact that sexuality stopped. The band testified, and then comes the moment that there was no sexuality anymore. Out of respect for her, we are no longer going to have sex for fun, because when you went through all this, the fun is gone. And it has always been like that, for almost 25 years now. I was not going to push her, because there was no sex for fun anymore. The woman continued, I just think about the pain and the shame with which it was accompanied. Sex never came up again in me. It was something nasty, something gone, nothing for us. Clearly, that was proven. We could not have children, and seemingly, yeah, that is something that I realized later. It was not for us. Okay, we had to let go our wish for a child, and therewith, so to speak, my libido was gone too, as a kind of collateral damage. The woman further reflected, and then I thought, it will become okay with our sexuality. It will become okay. But after some time, you grow apart. And sex is also a little bit a habit. And when you stop doing it, then you lose it a bit. Maybe not so much technically, but how do you initiate sex? That was all gone for me. And I thought in the beginning always, it will become okay, it will become okay. I cannot do it. He has to do it. He has to take the initiative. Not the initiative in bed, so to say, but take the initiative to find a solution or whatever. Because I cannot do it. That was a little bit stupid and faint-hearted, but I just tell what I felt at that time. To which the man responded with, I do not blame her for anything. Clearly, we have always been very dedicated to each other in our life. We have never grown apart, or there have never been extramarital affairs during that whole period. I've learned to accept it, but I have also been too weak. I really should have talked with her, and I'm sure that it would have been solved then. I have not been too weak to demand sex, but rather to bring it up. I really have felt lonely at times in our relationship, not connected with a woman that I love and with whom I have children together. The pressure they felt about sexuality was also expressed by the woman as follows. From the moment he came closer to me, I felt completely overwhelmed by the disappointment. So the meaning of coming closer to each other brought a lot, everything. Hope, anxiety, sadness, all these emotions came together with him coming closer to me, and yes, that was frightening me. And as a result, the man said, I stopped because I noticed that it did not happen anymore. Yeah. And then we also had our children. And yeah, I should have talked and take the initiative. I've done so later, in the 90s, but I was so cantankerous that it did not work out well. A last theme that emerged from the interview I had with this couple was sexual recovery. As I told before, the sex therapy sessions ended successfully, and as a therapist I was wondering what was most helpful for them to take up sexuality again. I asked them, what did help you most to get you back on track? It has often been so close and the barrier was so thin that it could have happened. But unfortunately, you also told during the therapy sessions, if you would have known this, that it was only such a small step that I and my husband had to take, then we would never have been here. She responded, my realization of the fact how difficult it has been for him, and my love for him. I think to briefly summarize it, the surprise of how much pleasure it brought to myself, and the warmth that I received from him, and the feeling of oneness, the feeling from the past that, suddenly came back. And the man continued, well, for me, at a certain moment I was so fed up with it that I wanted to divorce. I was really so fed up with it. And at that moment, we have hugged each other, and then we have had that breakthrough. I replied, thus the possibility of loss was finally the biggest motivator, because if you say that you wanted to divorce, but then start to hug your partner, then this means that there are two conflicted things that are brought together. But that is a sign that I see more often in my consultation, an extreme message that people give, and the man continued my sentence to force changes. Although there is much more to say and to reflect on the case of this couple, the time foreseen for this presentation does not allow me to do more than share this short conclusion. I believe that this case study really shows that it is necessary to discuss sexuality during a fertility treatment. This should be done before treatment because the link between sexuality and fertility requires an accurate sexually history taking. Also, because of a lack or badly timed sexuality can be a cause of subfertility, and also because sexual problems can occur due to problems with fertility. This discussion should also be done during treatment because it is important to discuss the possible influence of several aspects of the treatment or treatments on sexual functioning and sexual experience of couples. It also may help to normalize the experience of couples, which can work preventive and speed of a diagnosis, treatment need, or treatment of eventual sexual problems. And this should especially be done after treatment because fertility leaves couples with a sexual battlefield, I believe, of which both partners must recover. And it is necessary to inform, counsel, and or help couples to enable them to restart or regain their sexual life with or without a child or children. I would like to thank you for your attention, and if you would have questions, you can send this to paulenslin@kuleuven.be.
Thank you, Paul. This brings us to the end of this symposium. We hope you enjoyed hearing a bit about what is going on currently, what kind of research is being done at the Institute for Family and Sexuality Studies at the University of Leuven in Belgium, in the area on the topic of sexuality and relationships. And you can find us online, visit us if you want to stay up to date on the kind of work that we're doing and on new publications. You can visit our website ifss.be. Again, thank you very much and have a great rest of the day.